So let's turn also a big question of what does TMB mean today? Is this something that you guys are going to be ordering routinely? Should everyone be doing this as part of their initial workup? Jared, what are your thoughts?
So I think we're getting it by default in a portion of our patients already. So there is something of a divide in the non-squamous patients and how molecular testing is being done, with I think academia being wholesale pretty much sold on next generation sequencing with advanced bioinformatics, and a community divide where some are still doing a la carte testing with its advantages of greater speed in some cases and lower cost, but disadvantages of perhaps lower sensitivity for classical changes, and as well certainly less breadth of coverage for rarer changes actionable with off-label drugs and trials. But TMB, if you're getting next-gen with the most common commercial platform used in the US, as well as most academic platforms, you're getting TMB anyway. So for a little over half of our non-small cell, you have that data whether you're ready to use it or not. I think the harder question is, should squamous patients be offered comprehensive molecular testing for the purpose of getting TMB? I think in clinical practice, we've had protocols for years now to get next-gen on these patients, and if I'm going to be honest about it, I can't remember if I've ever been able to action one as a consequence. So that's not really a very satisfying answer. I don't know that this data is good enough right now that I'm enthusiastic about getting next-generation sequencing in my squamous patients purely to get TMB.
Greg, what do you think?
I mean, I think TMB is clearly a biomarker. We've got all sorts of lines of evidence that say it's a good biomarker. But I share your reluctance to say it's a routine today. I think the key thing that I'm waiting for before I tell everybody you got to test every patient beyond those, as you suggest, we already get it on. Once we have an FDA approval that says high TMB patients should get drug X, then I think that's right. I would push to get it done more frequently. We get it right now as part of next generation sequencing. That's the platform that we're going to build off of, and we're just going to expand that when we have an FDA approval in this context. But today we don't have that, and as a consequence, it's hard to say that it's routine.
I would even say that the FDA approval, if or when it comes for this, is not necessarily going to be enough for me to say it's clearly necessary to use or even that valuable to use in clinical practice yet. It's not. These data are very provocative, encouraging, especially the potential for a longer term response, and maybe particularly in the approximately 16% of patients who have low PD-L1 and high TMB, or negative PD-L1 and high TMB. That's a group where I don't think we're hitting it out of the park even with the chemoimmunotherapy. But I would say that the comparisons that are just to doublet chemo just don't apply that much. The standard has changed, and we shouldn't be measuring with that yardstick anymore. We are not talking about overall survival yet. So even if we can, I don't know that it really means we should. I think it wouldn't necessarily be wrong, but I don't know that it would be my leading choice.
It matters a lot the direction you ask the question, right? So if you're a practitioner anxious to implement ipi-nivo, maybe you have a super fit, super motivated patient who's clear to you what they care about is some chance at durable control. If you're looking at it from this perspective, then at that point it becomes mandatory to get the biomarker before you do it.
Yeah. Do you?
So I would just add that I will add a little bit of sprinkle of reality here. You know,
just a sprinkle.
Just a sprinkle. That not all people are actually getting TMB. So at an academic institution like mine, I'm getting next generation sequencing, but I'm actually not getting TMB in real time. And I think that's true for probably half of the community practices out there. So I don't think we're quite ready to say within 2 weeks of seeing a patient, I'm going to be able to get TMB back, and I'm going to be actually using it in real time to make decisions. And I think till the OS data really come out, and like you said, till we have an arm, which is a triplet that's being compared to, you know, a TMB-driven combination arm, I'm not quite sure that we can flatly say we should get TMB in everyone.
Another issue is that the fact that we've circled this point that TMB is a predictor of some value pretty consistently, but not necessarily unique to that regimen. That right. TMB may just be a marker for responsiveness to immunotherapy, whatever way you're delivering it with whatever agent.